Right now, we are at the end of our service. Please do stay on because we will have a talk by Dr. Amanda. She'll be giving a talk with regards to seeing things, schizophrenia.
Right, we're going to have our special talk right now, and we are so glad to have Dr. Amanda Albert once again to share with us in the second talk in a series of 3 talks on mental health. Dr. Amanda is a member of the Royal College of Psychiatrists, and she's currently a psychiatrist and lecturer at UNIMAS, Kuching. She attended New Life when she was a JPA scholar and was such a blessing to us as a church. She was a Campus Alive youth leader, as well as was a very active member of the worship department. And most importantly, I found that she really has a heart to help people. And I think that was what caused her to specialize in psychiatry, so that she can help people get back their lives, which has been turned upside down by the challenges of life. So today's talk is entitled Hearing Voices, Seeing Things, and Schizophrenia. And over to you, Dr. Amanda. Let's give her a warm welcome. Amen.
Okay, hi, morning, everybody. It is great to be back again this week. I am very thankful for the opportunity. I am not sure how many of us were here last week, but last week we talked about depression, right? Mood disorders, and this week we'll be looking at something a little bit different. So I'm happy to take questions along the way if anyone has questions as we go, or if anyone would like to wait until the end to speak up, or you can actually type the questions. I'm happy to take them. But today our talk is about essentially hallucinations, hearing voices, seeing things, or are we dealing with schizophrenia, right? Which is a major mental illness. So if you remember a variation of this slide that I put up last week, this is a broad overview of mental health problems, okay? And last week we talked about mood disorders, which is the first one up there. We talk about depression, which is extreme sadness, very consuming sadness on one pole, as well as a little bit about bipolar disorder. So 2 poles, extreme sadness and extreme happiness. And it's consuming on both ends, it's damaging on both ends. So somebody swings from one to the other, okay? This week, we'll be talking about what we call psychosis, okay? So psychosis basically means experiencing or believing things that are not real. So others don't experience it, but this person who suffers from psychosis experiences it. Okay, so one of the main disorders in which people experience psychosis is schizophrenia, right? So this would be the one that we'll be talking about today, right? And then next week we'll cover something else. Okay, so first things first, what exactly do I mean when I say psychosis? Okay, sometimes it's used quite loosely, when somebody insults someone else and says that this person is a psychotic person, right? I mean, in the medical field, there's a very specific definition for psychosis, okay? So there's basically 2 parts to psychosis, okay? You can have one or the other, or you can have both. One part is called delusions. Okay, so a delusion means a false belief that is fixed. So you believe in something super strongly, and you hold on to that belief, even if there is proof that the belief is false. Okay, one important criteria that it would be needed for a therapist or a psychiatrist to diagnose you with a delusion is the fact that a delusion must be out of the context of the person's social and cultural background. So in that case, there are some local spiritual beliefs that people have. We are not so quick to diagnose people with delusions when they have a strong cultural belief that is shared by their family or shared by their society. In those cases, we would be a bit more careful to immediately diagnose it as a delusion. Yeah, like say in some Malay societies, they believe in a spirit that can pass down from one generation to another. We don't necessarily that straight away diagnose someone as a delusion if they experience this. Okay, so it needs to be something that's out of context of the person's cultural background. Okay, and it must be a fixed belief. And some of the themes that you may see in somebody who experiences psychosis would be a delusion, what we call a delusion of persecution. So believing that somebody is out to harm them, that there's this big plot from the neighbors, from your family, from your friends, and the government, all planning to harm you. All right. Sometimes another theme is religion. So there are religious concepts inside, even Christian concepts, but when you examine it against the scripture, it is out of context, right? It is not within the proper understanding of scripture, so it's taken out of context. Sometimes there's the sense that they're being given specific missions by God, being visited by the angels, but the description of the event is actually very much out of context, right? So that would be that can sometimes happen. Okay. Some other themes include jealousy, strongly believing that your partner is, in a relationship with somebody else, but when actually that's not true. Delusions of reference, believing that everything that people talk about, even what the TV and the radio show is talking about you personally, that's a delusion of reference. And basically other bizarre things. Bizarre things means things that are just impossible, right? Very, very strange things that are impossible. But these are actually experienced as very, very real by the person who experiences psychosis. So they experience it as, really, really true, 100%. I stake my life on it. If you show me anything against it, and you are part of the conspiracy, right? It's a strong, strong felt belief. That's a delusion. Okay, that's one part of psychosis. The other part of psychosis is hallucinations, which this one we may have heard of, right? You perceive something that is not real. The specific definition is there is nothing that produces sound, but you hear a sound. There is nothing that is in front of you, but you see something. Okay, in certain settings in the Bible, when God speaks, this may have happened as well, or when they saw visions, right? But in this case, hallucinations are quite different, all right? Because it occurs in the context of a mental illness. It involves any of the senses, okay? So a hallucination means that it can involve the sight, the hearing, right? So hearing things would be hearing voices, right? Voices criticizing you and things like that. That's hearing. Sight would be seeing things, seeing ghosts and things like that. Touch would be sometimes people feel ants crawling on their skin. That is a tactile hallucination, a touch hallucination. Okay, and then olfactory, meaning smell. Okay, so smelling burnt rubber, sometimes that's an indication of a tumor growing in the brain, or a kind of a specific type of epilepsy or fit that causes you to experience a smell hallucination. Okay, and the other one would be taste. So some people have a taste in their mouth. That's a taste hallucination. No matter what they do, that taste remains. Okay, so a hallucination can be perceived as so real that the person responds to what they are experiencing. So sometimes you see people talk back to the voices that are speaking to them, right? And that can explain some of the behavior you see from somebody who is not well, who is on the streets, right? Sometimes you see them doing funny things, and you see them talking to the air. And sometimes that is actually talking back to hallucinations. So it's quite likely that this person has not had medical treatment or has not sought treatment for the hallucinations. So it's become so vivid, it's become so strong that they talk back to the hallucinations. Yeah, and this can be extremely distressing. If you think about this, the psychosis will be something that's experienced as very real to the person. So when you experience something as very real and other people don't experience it at all, or other people tell you that what you're experiencing is not true, it's fake, it's it's just your imagination and things like that. Can you imagine how alone you would feel in the world as somebody who experiences something alone that no one else experiences and nobody understands, right? So this is the thing that happens with psychosis that makes them somehow, that can really isolate them from society. Okay, if you experience psychosis, it can really isolate you because you experience it alone, and it can be terrifying. It can be very, very traumatizing. So psychosis often causes a change in behavior, right? If you constantly feel like the world is out to harm you, then you hide in your room, you start to keep weapons, right? And things like that. If you strongly believe that your spouse is unfaithful and despite no evidence for it, then you'll be constantly checking, there'll be conflict, right? So it really, really can impact daily life and relationships. Okay, so if you were to believe that somebody is spying on you, putting on cameras in your office, then you'll be climbing the walls looking for the cameras, right? And of course no work gets done. Okay, so you can see how this experiencing psychosis would really impact a lot of aspects of somebody's life. Okay, so now that we have an idea of what psychosis is, we mentioned that schizophrenia, people can experience psychosis in the disease called schizophrenia. Okay, but one thing to bear in mind is that psychosis can occur in a few of these other mental health problems. Okay, they can occur in severe mood disorders. So somebody who's had bipolar disorder, a severe episode of bipolar disorder, or severe episode of depression, they can experience hearing voices or having very, very strong beliefs of something. Okay, they can experience that as well. Another setting in which this occurs is mental health problems from physical health problems. So it's not uncommon for someone who is on steroids or on an anti-Parkinson drug to experience hearing voices, right? So sometimes in those cases, the medications need to be adjusted. They need to talk to the doctor who is prescribing that medication. Some hearing voices, seeing things can occur in people with thyroid issues, or who you have a tumor that's growing in the brain and you start to hear and see things. But actually that's because there's a tumor that's pressing on the area of the brain that generates these sensations. Okay, and they can occur in a lot of cases, in some cases of dementia as well, or even when people have short-term changes in the blood. Like say if you lost a lot of fluid and your sodium in the blood, right, the electrolyte in the blood goes really low, you can start to experience hallucinations as well. So when you correct it, when we increase the sodium, you go to hospital, you get a drip put into you, and then you rehydrate yourself, the hallucination goes away, right? So physical health problems can lead to psychosis as well. And another setting in which that occurs is alcohol and drugs. So alcohol and drug-related disorders can lead to psychosis. As well, right? So if we look at the causes, the first most important thing is to remember that physical illness can cause somebody to have psychosis. Okay, so we need to look for whether there is any physical illness going on. Get a medical checkup done. Okay, temporary illness, I mentioned earlier. If you have a very bad infection, if you're delirious, right, you can have hallucinations temporarily. Okay, if there's a salt imbalance or fluid loss, you can have it. And then sometimes it occurs in longer term illnesses like thyroid issues, epilepsy, where you're continuing to have a lot of fits, multiple fits and seizures, and then you can experience hallucinations, brain tumors, dementia, right? So in all these, if we should aim to try and control the physical illness well, and hope in a lot of cases the hallucinations do reduce or do go away. Okay, that's one. The second one to consider is actually alcohol and drug abuse, right? Some very strong culprits will include methamphetamines, so basically ice or shabu, okay? Sometimes you see when people run amok, right, in the news, there may be actually not just a mental illness, actually, but more of alcohol and drug issue going on, right? And that can cause this kind of behavior. Cannabis as well. There's a very strong, there's a lot of argument for medical marijuana, right? Medical cannabis, using cannabis for painkillers, using cannabis for cancer treatments, things like that. But it's important to know that in young people who are stuck on cannabis early, a lot of them have very high chances of progressing to having a serious mental illness later. Okay, so cannabis basically, this is ganja, right? Ganja. Hallucinogens like LSD, if any of you from their 70s, the flower power era where people were taking drugs to hallucinate temporarily, right? Those can cause very vivid hallucinations. So things like LSD, right? And also chronic alcohol use. Some people do experience hallucinations with chronic alcohol use, but this is not as common. Now, after you think about those two causes, then the major cause that we're thinking about here is what I call true psychiatric illness, an actual psychiatric illness. Okay? So in actual psychiatric illness, psychosis can occur as a main symptom in things like schizophrenia, right? And other related disorders. Okay? And it can occur as an additional symptom, so a side symptom in things like mood disorders, like I mentioned earlier, right? In a severe episode of depression or a severe episode of bipolar disorder, you can have hallucinations or delusions as an additional symptom, so a side symptom, all right? But when you treat the mood disorder, then the side symptom does reduce and go away, okay? But it occurs as a main symptom in the disease that we're talking about today, which is schizophrenia, all right? So I hope we are okay so far. I mean, it's good to, I basically introduced this because I want us to have an idea that it's not always about mental illness. We need to consider physical illness as well, and as well as substances like alcohol and drug abuse. Yeah. So a major disabling cause of psychosis is the pure mental illness we call schizophrenia. Okay. So what exactly is schizophrenia, right? So loosely translated, it means split mind. Okay, it comes from the Greek roots schizen and phren, which are split and mind. Okay, so it's a split mind. Basically, it gives you an idea of the person's different experience of reality. I wouldn't say split. I would say different experience of reality, different beliefs, and different perceptions. Okay. Right? This is a major chronic mental illness affecting 1 in 100 people worldwide. Okay. So if you consider in a church of 100, it is not impossible to have 1 or even 2 people with schizophrenia. Okay. Symptoms. So that's why it's important for us as a church to know how we can support people who do have it. Okay. Symptoms will often start in the late teens to early 30s. It's a bit younger for men. So in the men, it starts in the late teens to sort of like early 20s generally. It can start in other ages, but this is the common age. And for the ladies, it starts in the late 20s to early 30s. Again, this is the most common age, but it can occur even in people who are older or even people who are younger. Okay. It affects self-care greatly, right? And it leads to a greater risk of early death. But this early death is usually from preventable medical illness. So you imagine when you have schizophrenia that is not well controlled, you're always out of touch with reality, right? And then that means that you're not aware of your physical problems. So you have preventable physical illnesses that you don't take care of. And that is what leads to greater risk of early death. Okay, so it's not schizophrenia itself actually, but it's the other illnesses like high blood pressure, diabetes that's not well controlled, infections here and there that are not well controlled because the person's not in touch with reality. Okay, so although schizophrenia is treatable, if you think about it, the stigma is still there, right? People say orang gila lah, and people say all sorts of other things, that make it hard for people who have schizophrenia to be honest about their problems. Okay, so stigma is still very strong. And in fact, in a lot of people with schizophrenia, violation of human rights is very common. People immediately assume that because you have a mental illness, you can't make decisions for yourself. So in Malaysia, if the person refuses to sign for themselves, for their own procedures, if they have a mental illness, sometimes family steps in and takes over to sign for them, which can be a bit risky, especially if the family and the patient don't get along well together. They may not have the patient's best interest at heart. So there is a risk of violation of human rights, which we try to protect under the Mental Health Act. So we have a Mental Health Act in Malaysia. We do try to protect patient rights via that. Okay, so there's very specific rules on who can sign and to decide whether a patient can sign for himself or not if he has a disease like schizophrenia. Okay, despite what you may have heard on the media as well, all the high-profile criminal cases, this person murdered that person, and has a mental illness, blah, 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 right? The contribution of schizophrenia to violence is actually still heavily debated. Okay? In fact, people who suffer from schizophrenia are at risk of being victims of violence. So a lot of studies have shown that they are at risk, actually, maybe even more than the general population, of being at risk of being victims of violence because they are not aware of what's going on, or when they are not well, they lose touch with reality, they get scammed all the time, they get injured all the time. Okay, so yeah, that's schizophrenia for you. So how actually is schizophrenia diagnosed? We need at least 6 months of any of these five symptoms. You need at least 2 of these 5 symptoms. Okay, but another rule is one of the symptoms must be the underlying ones. So at least one of the symptoms must be delusions, hallucinations, or speech that doesn't make sense, right? Some people with schizophrenia have speech that is all over the place, doesn't make sense, right? If they must have at least one of the underlying symptoms, okay? And then plus one of the others, or they can have 2 of the underlying symptoms. As long as you have 2 of any of these symptoms, including one of the underlying ones, for at least 6 months, you can be diagnosed with schizophrenia. Okay, but some very important criteria is what is below there. What it affects the important parts of their life, right? And so the family will notice this, a very strong difference from before and after, right? And the symptoms can be called that we have to make sure that the symptoms are not caused by physical illness or alcohol or drug abuse. If you have ruled all these out, then we can diagnose schizophrenia in somebody who's had 6 months of these symptoms. Okay, so you see now some of the other symptoms there, not the underlying ones, are muddled behavior. So behavior that doesn't make sense. What I mean is, for example, putting water in a pot, but switching on the fire in another side. Right? I'm doing things that don't make sense. Starting a fire in the house to burn rubbish, starting it in the house, right? That kind of thing, where the behavior is very muddled. It doesn't make a lot of sense compared to the previous. Okay, and then some people with schizophrenia also have negative symptoms. So you may have noticed this if you know people who do suffer from it. There's a reduced facial expression. Right? The facial expression becomes very flat. There's reduced motivation, don't want to do anything, no energy, no motivation to do anything. And I'm not speaking much. So these are called negative symptoms. Yeah. So what contributes to developing schizophrenia? Like you remember this image that I showed last week? This is a modified version. The concept is that a cake is not baked using just one ingredient. So schizophrenia is usually caused by a mix of factors. One would be there are some chemical differences in the brain, or there's some structural differences in the brain as well. So that would be how medications work. Last week during in depression, we talked about serotonin as one of the chemicals. Right here, we're talking about dopamine in the brain. So it's an issue of dopamine balance, and that's how medications work. Right. Another part of it is genetics, right? As with a lot of mental illnesses, if you have a family member who has it, your chance of having it is higher. Illicit drugs, especially, like I mentioned earlier, cannabis use in early teenage years, okay? And stressful events may trigger a diagnosis of schizophrenia. So maybe if you just have one of these and none of the others, then the schizophrenia doesn't manifest in your lifetime. Okay, but if you have a mix of them, then your chances of having an episode are higher. All right. So now that we've talked about what schizophrenia is, we want to see what schizophrenia is not. Okay, schizophrenia is not just an overactive imagination. The person who experiences it will tell you that they experience it as very, very real and very, very distressing. Okay. It is not a sign of lack of faith or punishment or possession, which we will talk about a little bit more later. It is not a person's fault. It is not a person's family's fault. Okay, we can't say that, oh, because this person didn't bring up the child this way, that's why they had this. Okay, schizophrenia is not that. Schizophrenia is also not split personality. That's a different issue altogether. Somebody with schizophrenia experiences things very differently from somebody who may have split personality. Schizophrenia is also more common than split personality disorder. Yeah. All right. And schizophrenia is also not the same as depression, bipolar, anxiety, all these other conditions, right? We want to differentiate them very clearly because the treatment is different. So again, just like last week, the good news is that there is treatment available. Okay, there is treatment and help available. Now, but this is a bit different from depression in that you will notice that I have made the word medication a lot bigger. Okay, it is a lot bigger because if a patient actually has schizophrenia, the treatment of medication is lifelong. Okay, so it is not like depression in which, okay, we can have a trial of medication and say sometime later we can try and take it off and see how the person does, right? Or in some cases of mild depression, you can actually go just for talking therapy without medication. Okay, but schizophrenia is very different. Okay, schizophrenia requires medication, and this is usually often lifelong for schizophrenia. Okay, if somebody experiences delusions or hallucinations due to other conditions, like other medical conditions or due to drug use and things like that, when the medical condition is well controlled or when the drugs are not used anymore, there is a chance that we can take off the antipsychotics, the medications. Okay? But if the disease is actually due to schizophrenia, then the medication needs to be lifelong. Okay, so the medication that we're talking about is antipsychotics, right? Another possible treatment that is used is also electroconvulsive therapy, but that is used in certain cases of schizophrenia where there is a risk of harm to self or there's a risk of harm to self. Okay, so in some versions of schizophrenia, the person reaches an extremely negative state where they won't take any food. They can just sit in the bed all the day long, right? And even if they are pushed, they don't react. Even if they are moved, they don't react. That's an extreme sort of like negative state, which we call catatonia. In people who have schizophrenia with this, then electroconvulsive therapy or electric shock therapy is a treatment to get the person out of it quickly. But of course, long term, you will still need antipsychotics, which is the medication. Okay, right? And then, of course, apart from medication, a big part of recovery from schizophrenia is really recognize talking therapy. So talking therapy will deal with, once the person is stable on medications, for them to deal with, okay, the idea that what I experience as my delusion is actually false. Trying to get the person to be able to recognize and to deal with delusions. Okay, if any of you have watched the movie, it's a Beautiful Mind, right? The one starring Russell Crowe, right? That's an idea of how he learned to recognize his delusions or recognize his hallucinations, right? I think it's a remarkable story, but I don't know of many people who can go through it with just talking therapy or just recognizing delusions like that. A lot of people will need medication. The vast majority will need medication. So his is quite a remarkable story, right? So talking therapy helps once the person is stable on medications. If you're still experiencing hallucinations, still having these strong false beliefs, right, and you're out of touch with reality, no amount of talking therapy is going to help. So we need to treat with medication first. Once you're stable, then we can talk about talking therapy. So to deal with delusions or to deal with hallucinations and to help with any other difficulties that arise, right? Somebody who has schizophrenia or who has an episode where they acted out, right, and everybody noticed, sometimes there's a stigma that comes with that. It's quite hard to recover from that in the workplace or even among family members, right? Sometimes it's hard. So sometimes talking therapy needs it is needed to help to deal with that. Okay, so we want help. They may need help with self-confidence, with memory issues, with social skills, rebuilding your life, basically, right? So that's where talking therapy comes in. Now, our role is actually in terms of this. Our role as the layman is lots of support and rehabilitation. Okay, so the above ones are generally for the professionals, like the clinical psychologists and the psychiatrists, the therapists. The ones at the bottom, we can do a lot of, right, as laymen. So lots and lots of support and rehabilitation are needed, right? Sometimes somebody with schizophrenia forgets how to care for themselves. Self-care is important, right? Compassionate support. Now, I put this in caps lock because it's very, very important. I think the greatest thing we can do is to actually show compassion for sufferers of schizophrenia, right? So rather than treating it like something that is because of some inner sin, right? It's like a punishment by God or things like that. Somebody trying to be difficult when actually they're just mentally unwell, right? When they have taken medication and they've recovered, we do need to offer a lot of compassionate support. And that is really our role. A little bit more about compassionate support later, right? The person with schizophrenia also would need to form social circles, right? To find some support groups. A lot of the time, they need assistance with studies or employment, right? Especially, you remember that schizophrenia, a lot of it, the first episode occurs when the person is actually really young, right? So in uni level, college level, still studying, just starting to work or just starting to, progress in their career, and this hits. So there may be assistance needed with sort of like trying to recover some of that, right? Once the person is stable on medication. And in some cases where there's no family support, they may need a little bit of help with assisted living, right? We are still a bit behind in this here, but overseas, there's a lot of help for people with schizophrenia to live independently in terms of assisted living, okay? Over here, we still rely a lot on family members, or sometimes they will end up going to psychiatric nursing homes. But this is something to consider. Yeah, so now that we've, this will be a question that gets asked every time because of, in our walk with the Lord, there is room for the supernatural experience, okay? And God does work in the natural realm as well as in the supernatural realm. That one, no contest, right? No argument about that. But I would advise actually a few guiding principles with regards to whether we are talking about schizophrenia or spirit possession, okay? I think a big mistake we don't want to make is immediately assigning all supernatural experiences to spirit possession. If somebody could actually be suffering from an actual mental illness that needs to be medicated. Imagine if we just immediately diagnosed it as a spiritual issue and we only use spiritual measures. The person could go on for very long without getting the medication or the help they need. And schizophrenia long-term without medication can lead to brain damage in its own way. So we really, really want to try and avoid that in churches. And I think increasing our awareness is a good way to go about it. Okay, so a few guiding principles from personal experience as well. Okay, for the majority of people with pure mental illness, there is no involvement of spirits. I wouldn't say that applies for all. Yeah, perhaps there may be some involvement in some cases, certain individuals and things like that, right? It's a case-by-case basis. But for the majority who have pure mental illness, there's no involvement of spirits. Another thing is that many people with schizophrenia actually respond well to treatment. So once we find the right medication, we find the right dosage, we find the right treatment regimen, the hallucinations and delusions do reduce gradually, and they do disappear, in fact. Even more so if it's due to a medical illness, like say if it's due to an uncontrolled thyroid. Once you bring the thyroid under control, the hallucinations go away. And so in these cases, I would say that there is very little argument to talk about spirit possession. Okay. Now, the other thing about it is also that sufferers of schizophrenia, if you look at the examples from the Bible of demon possession, right? Spirit possession, and you compare it to sufferers of schizophrenia, sufferers of schizophrenia generally do not possess any spiritual knowledge, and they do not have a violent reaction to the name of Jesus, as compared to the examples from the scripture. Okay, that would be, of course, this is all on a case-by-case basis, I would say, and it's but these are the few guiding principles I have, right? The main takeaway for us, I think, is to not be too quick to think about just pure spiritual issue, but to actually think about the fact that we could be dealing with a physical illness or a mental illness here. Yeah, that would be something that would be great if churches can continue to pick this up. Yeah. So how can the Christian help? Just like last week for depression, I think seeking understanding is a great way to start, to read up and to listen to sufferers' experiences. Okay. Remember that mental illness is not always primarily spiritual, so therefore do not rush into giving spiritual advice. Do try to listen and discern as to what is going on first. And I would actually really, really recommend practicing compassionate support. Okay, and by this I mean practical help with everyday things. So everyday things meaning things like transport, things like family support, things like helping people with schooling, helping with employment, things like that. Compassionate support. Okay, encouraging professional follow-up. It is unfortunate that in some spiritual circles, sufferers of schizophrenia or major mental illnesses are told not to go and see the psychiatrist, that the psychiatrist is only secular, that they are only treating you secularly, that the clinical psychologist is only treating you secularly, that dependence on medication means you are not dependent on God, right? I think this kind of thinking is actually damaging to somebody who actually has an illness that could need medication lifelong. Okay, we are talking about lifelong medication like diabetes, hypertension, and a lot of other major illnesses. Okay, so schizophrenia is in the same group as these, just that their symptoms may not be so visible to the eye, visible to the person. Okay, so I think a big thing we can do is actually to encourage professional follow-up, right? Unless you find that there is a major issue with the doctor that the person is seeing, then you can consider seeing another doctor or another therapist that is more suitable, maybe. But then by all intents and purposes, we should be encouraging professional follow-up, okay? Because we need the professionals to take care of that part, and we can take care of the spiritual part. The professionals do need the church to provide the extra spiritual support and the social support that the patient needs. So both sides actually, in a way, are both helping the patient together. Okay. I also recommend extra understanding and allowance for difficult situations when somebody is unwell. Sometimes when somebody is unwell, there may be certain behaviors that come out that are not typical of the person. There may be even a major episode that draws a lot of attention in the church service time, and things like that can be a bit awkward, that can be a bit difficult. If you know that the person has a major mental illness, then we do want to give some extra understanding and extra allowance for that. Okay. In the same way, when somebody is unwell and they answer you in a rude manner, for example, when they're actually normally very polite and then they're very rude, or they do things that don't make sense and they cause you inconvenience, perhaps it's good to identify that maybe is this person being unwell and that's why he's behaving this way. So don't take it personally in that sense. Yeah. So these are some ways in which we can practice compassionate support as individuals and as a church. Right. So I found a really good write-up about this on God Questions. So God Questions is this website that has a lot of scriptural answers for real world questions. Okay, so I thought that this kind of summed it up quite well. Okay, and I'll read it for you. Believers, they write a whole article, but this is at the end of it. Believers should be filled with compassion for those suffering from schizophrenia. We can think of it as a prison of the mind. Okay, people with schizophrenia and their families typically lack support from both the Christian and medical communities because neither one has all the answers. And the church should minister to everyone, including people with schizophrenia and their families. So this is what I mentioned earlier, that actually the professionals, the mental health professionals and the churches can work together to help the patient together because you both cover a different need, right? And although the Bible does not specifically address brain or psychological problems, it does refer to people being healed of all types of maladies, okay? So the Lord works not only through miracles, but also through medications, surgeries, counseling, and environmental changes. He does not want anyone to remain in hopeless suffering, and he calls all to come to him with their burdens to find life. Remember that life is what we're talking about here, okay? If schizophrenia is lifelong, then we may not be talking about a full and complete healing. It may not happen for everyone. Yes, it can happen if the Lord wants it to, full and complete healing without medication. But for the vast majority of people, the Lord brings healing through medication if you have a lifelong condition like schizophrenia. And yet you can find life in that as well. Okay, the Lord also calls his children to extend love and the gospel to those who hurt, especially upon those who are the most vulnerable. And we have mentioned that people who suffer from schizophrenia are vulnerable. Yeah, and the Bible says that anyone who calls upon the name of the Lord shall be saved. Those who suffer with schizophrenia can have hope in Jesus for life more abundant, and the Lord can use all things for their good. So I thought that this summed it up quite well. That the Lord does work in many ways, right? And we would do good to educate ourselves and to actually respond in a way that is not just spiritual, but that actually looks at the other aspects of the psychiatric illness or the physical illness for somebody. All right. So that's in a nutshell, basically what psychosis is and what the major mental illness involving psychosis is, which is schizophrenia, right? Any questions? Oh, there are questions already. Let me see. All right. Pastor David asks, will electroconvulsive therapy erase off parts of memories in the brain? Memory issues are one of the common side effects of electroconvulsive therapy, yes. But for the majority of people, the memory issues should be short-term. So we should get the memories back within a few months. But for some people, some of it is lost. Yes, that does occur. So if you are on a long course of electroconvulsive therapy, some people require it over a longer period of time. Your doctor should actually be monitoring your memory regularly over a period of time. Okay, because if you do have very lasting memory problems due to ECT, then your doctor should be able to make certain modifications to the ECT, the electroconvulsive therapy, or maybe he will consider you as a candidate that is not a person who is not so suitable for electroconvulsive therapy due to major memory effects. So bottom line is, if you are on a long course of electroconvulsive therapy, your memory should be monitored over time. Yeah, and for the memory issues do not necessarily become permanent. A lot of people do report some loss of memory, but some do regain it back as well. Yeah, so it's on a case-by-case basis, and I think it definitely, if there are issues with memory, it definitely should be brought up with the doctors. Bear in mind that electroconvulsive therapy is something that we use for when you are at high risk. So when you're at risk of harming yourself, imagine just not eating the whole day, just lying down in the bed, or not even responding when somebody pushes you when you fall down, that kind of schizophrenia, right? To think about it, you would not last a few days even with that. Okay, so losing some memory may be almost like a trade-off between that kind of life-threatening episode of schizophrenia and losing the memory lah. Yeah. So it's a tricky balance. I think it's a tricky balance. But we should definitely monitor memory. I agree. Yeah.
Thank you so much, Dr. Amanda. Thank you so much. Actually, I'd like to just say this. Really appreciate the session, this kind of talk, coming from you as a Christian psychiatrist, to give a balanced view from the professional side as well as the spiritual aspect. Yeah, I wish we had this kind of talk much earlier. When in the early years we encountered numerous cases of cases like this, and we didn't know how to handle really. Of course, in our own as pastoral care, we apply a lot, through prayers, through whatever means that we had.
And that was
it was really difficult. It was really difficult, yeah. Including trying to cast out whatever spirits and demons out. So we really didn't know whether it's demon or human.
Yes, that's
but what you presented, I really appreciate the balance of this view. Fantastic.
I'm actually glad to do so. In a lot of ways, I am still forming my experience on certain things. And that's always a question that's asked. In fact, this topic, this is the reason why some Christians feel like it's a conflict, like it's difficult to go into mental health. They find it difficult to go into further study as a psychologist or as a psychiatrist because they find that this part is a bit ambiguous or a bit conflicting for them. But I find that there are some very clear guidelines we can use and to actually maintain a balanced view of both sides. Yeah, for both sides. Thanks, Pastor. Uncle Gary asked here.
Amanda, 我有啲嘢想問你啊。something I want to ask you. My blood pressure is 3.8 Is it normal?
Blood pressure?
My blood pressure 甜尿啊。
甜尿上一次咧就係4.8。4.8都係尋日前日。
5點幾。
Blood pressure is it?
Not blood pressure, the sugar.
Oh, sugar.
Sugar, huh?
That
is it's 3.8 before eating or after?
Now, yesterday I checked already. It's 3.8. Yesterday, before yesterday is 4 point something, and then before yesterday is 5 point something like this. Before the thing, not yesterday. Before the.
Is that before eating or after?
No, eat nothing.
Eat nothing.
Fasting.
Okay. Do you feel giddy? Do you feel giddy or lightheaded? Giddy?
You No, I didn't feel anything.
Okay. So if you didn't feel anything, that is okay. No problem.
Yeah. Thanks a lot.
Yeah, if you don't feel giddy, that is okay. All right, that reading is okay.
3.8 okay咩？唔會好低。
It's okay. No, it's quite low. But if you don't feel giddy, it is fine. It's okay. No problem.
2-3個禮拜前係 4.8， so 尋日起量做3.8 come down.
Right.
I don't know why.
Right. That's okay. As long as you don't feel sick, you don't feel giddy, you don't feel like vomiting, that's fine.
Oh, sometimes I vomit,
Sometimes 頭先有冇？
very hard to breathe, or when I drink, suddenly I cough like this.
咩？有時即刻。
Yeah, then in that case, you may need to see the doctor that you are that is giving you medication and see how you go.
睇醫生咯。
Yeah.
你好似好奇怪咁。
But if you don't feel anything, that reading is fine.
Sometimes I eat, suddenly not eat drink. Suddenly drink water, I want to vomit like this.
So if that goes on for some time, you should definitely talk to your doctor and see. They may need to check lah. Yeah, they may need to check some things that I can't check from here. Yeah.
My heart, don't know, my heart beating is normal. I don't want to see doctor if I keep vomit. Sometimes not keep vomit, sometimes I vomit.
Yeah.
Not very comfortable.
If it's always like that, you should see a doctor lah. And see what the doctor has to say.
These few weeks, sometimes I want to vomit also this few weeks.
Suddenly,
Raymond, go and 睇醫生 ，OK， 可以睇醫生 ，OK， 睇醫生最好。
Okay.
Okay, thank you.
All right. Take care, huh? Take care.
Take care.
Yeah.
Okay, there are some questions. Chat box.
Yeah, there are some questions here. Uncle Gary asks, is childhood schizophrenia common, and what are the signs? I wouldn't say it's common compared to the age group that we're talking about, right? Late teens to early 20s, late teens to early 30s, that's what age group. But it does exist. It does exist. Probably my experience is limited at the moment in that sense, but the youngest I may have seen is probably 15 or 60. It's not super common, but the symptoms tend to be similar to adult schizophrenia. So the experience of hearing voices, the experience of having some very strong beliefs on certain things, strong beliefs that can't be shaken, right? That is not typical for the age group, right? So it's similar. And then often there is a change in behavior. There's a decline in the academic performance or a decline in the social circles, doesn't mix around much, right? So you may see that. But I wouldn't say it's super common. All right. Chan asks, any written guidelines for us to compassionately, systematically convince an unwell person to see a Christian psychiatric doctor? It is very tricky. It will take. It's just like depression. Sometimes it's hard to come to terms with the fact that you may need to see a doctor, and people find it much harder to come to terms with seeing a psychiatric doctor compared to, say, a general doctor for a heart problem, for example, right? So I would say that you can continue to just be a friend, continue to be a friend, continue to be there for the person, continue to encourage. So they may not agree after one suggestion. You may need 10 suggestions, you may need 100 suggestions, but to continue to encourage and maybe to look out for any doctors that are well recommended, especially if you're looking for a doctor in Christian circles, then try and look and see. Another way, right, is to actually get if this is your family member or your friend, to actually go and see a general doctor first. Like just say for a medical checkup, because remember that before we treat a psychiatric illness, we want to make sure we're not dealing with physical illness. So you can actually get them to see a general doctor first, but you tell the general doctor your concerns, whether this could be a psychiatric issue or not. Sometimes people won't listen to their family members, but if a doctor that they trust or a doctor that is good speaks to them, they will listen, even if it's a general doctor. So if the general doctor suggests going to see a psychiatrist, then they may agree, right? Another way is actually go one step in a threatening. So what you can do is actually to try and suggest maybe a counselor instead. And a trained counselor will be able to identify when a person actually does need to see a psychiatric doctor, that the person can't just be treated with talking therapy, but actually needs to see a psychiatric doctor for medication. So there are a few ways. There are a few ways. You can go and see other professionals first that may be less threatening to the person. and you can continue to be there and just continue to encourage the person to seek treatment. I think those would be the few ways that people have successfully brought their family to see doctors before.
Thank you, Amanda. Yeah, for your answer. That's helped.
Right. Okay.
That's Jawi.
What is it? Oh,
That's Jawi.
It's Jawi,
Right.
yeah.
Yeah, do you show your
right.
photo?
Oh,
Right.
from far away. Wait, this as in Jiaowei from where?
Germany.
Oh my goodness, so long. It's been so long. Oh my goodness.
Right. Yeah,
Something
catch up
like-
with you again. I'm in Singapore. Okay. Yeah.
Yep,
so
yep.
there's a question
All
here.
right. All right, glad to help. Right. Dr. Ui asked, why are the following examples being classified as positive symptoms? Yes. Okay. Hallucinations, delusions, and what we mentioned just now, right? Muddled thinking, disorganized thinking. Okay. We need to know that in this setting, positive symptoms doesn't mean like positive, like positive thinking, positive outcomes, right? Something good, positive. And then negative symptoms mean something negative. It doesn't mean that. Positive and negative in this case is mathematical. So positive meaning plus, you add something. Negative meaning negative, you take away something. So when somebody has, let me see if I can go back to that slide. If somebody has positive symptoms, right? Hang on. Yeah, positive symptoms, delusions, hallucinations, or disorganized thinking, disorganized speech, right? Those cases, you have added something. You have added something to the person. So I never experienced delusions before, but I now experience it. So it's an addition. I never had hallucinations before, but now I experience it. So that's an addition, pertambahan, right? So that's why it's positive. You add something to the person's experience. Disorganized thinking, I never had it before. I have it now. I added it. It's added into my experience. So that's positive symptoms. Negative symptoms are when things are taken away from me. For example, my facial expressions, I begin to lose them. That's negative. It's taken away. It's minused, right? Motivation, my motivation is taken away. My speech, I speak less. So it's taken away, then that's negative symptoms, right? So I hope that clears it up. Positive symptoms means that it's added, an added experience, and negative symptoms means it's an experience that's taken away. So delusions, hallucinations, disorganized thinking, and disorganized speech would be positive symptoms. And then negative symptoms will be, reduced facial expression, reduced motivation, reduced speech. Yeah. All right. Anybody else? Any further questions?
Yeah, very good so far. That's fantastic. Amanda, really good.
Yeah.
Yeah. Actually, I had a lot of questions, but along the way, all my questions have been answered by during the talk.
Right.
Yeah, very good.
Hi, Dr. Amanda.
Hello.
I'm Julianne.
Hi.
How do you know when the negative symptom, the lack of speech and motivation, could be caused by the medication slowing the person down so much the person doesn't feel like talking, the person is lacking motivation? How do you know when it's the illness and when it is a side effect of the medication? Because when you're tired, the medication makes you so tired, you just don't feel like doing anything.
Yeah.
How do you know? How do you know?
Yeah.
And sometimes there was a case where after they changed the medication, it's like you don't even feel like talking. There's nothing going on in your mind. You can't talk. And then you get scolded, like your father tells you, how come you're so quiet at the cell group meeting? You're not talking, but there's nothing in the mind. Then later on, when there's a change of medication, then suddenly the person comes alive after 2-3 months of the new medication. So it would appear to be the medication that's causing the mind and the lack of motivation. And with the change of medication, the person has ideas about how to live and is motivated once again to live and is able to carry on social context, talk to people.
Yeah.
I would say that sometimes it's the medication. So how the difference?
Yeah.
So hard to tell.
I agree that it's hard to tell. I think it's probably quite difficult to tell just on the basis of that itself. I would say that somebody who does have these negative symptoms as part of the illness of schizophrenia should have some of the other symptoms as well. So for example, if I'm having this, I'm not speaking, I have no motivation to do anything, and at the same time, that's because at the same time I'm still having this these strong beliefs that people out to harm me, right? There's a strong belief that there's some plot out to harm me, and then at the same time I'm still hearing the voices telling me I'm no use and things like that. Okay, if this occurs in the context of all those other symptoms as well, then I would say it is I would say you should consider it as part of that illness, and we should try to treat, at least get the positive symptoms under control.
Counseling alone, some of the so-called delusions, because sometimes it's just that you think certain thoughts and you think it's from the Holy Spirit, from giving you discernment. You're not sure what is going on. It seems so real, and of course the enemy likes to add all sorts of salt and pepper and all sorts of ideas to your mind. And then just the memory is just alerted to certain things, and you think, oh my goodness, that's the case, and you start forming, and it's like it doesn't happen in one day, it happens over months, and it builds up to the point where it's like, then when you talk, if somebody asks you, and then you start wondering about things, and somebody asks you about it, then it sounds like you're having delusions to other people, because you think it's so real, and other people know that can't be true.
The thing about delusions is we don't diagnose them too quickly, I would say. There needs to be a certain degree of for lack of a better word, abnormality to it. By abnormality, I mean it is out of your usual context. Okay, and it has to be to an extent that it interferes with your life. To what extent is that belief harmful to your life? And to what extent do you hold on to it until it consumes your life? That's what a delusion does. So I would say, you see, when we diagnose schizophrenia, we have to measure it against how much damage it's done to the person's life, or how much damage it is doing, right? So of course, if you were to experience something where it's a thought from the Holy Spirit, I think a good thing is to really, really test it against the scripture. That's super important to see whether it's in context or not. All right. Anything that is out of context with scripture, I think we should be very careful about that. We cannot attribute that to God, because God is consistent. But you see, if it's the belief is so unusual for you, and you hold on to it so strongly, to the extent that it's not shakeable, to the extent that it puts you sort of like it puts you how shall we call it? It causes concern to the people around us who know us the most. Then I would say that we may need to be a bit careful about that, especially if you do have some sort of an illness where there is a delusion involved. Then that could be a delusion. A lot of delusions spark from an original valid thought, but sometimes it comes from there. All this is it's a little bit tricky. Again, the measure is how much it disrupts one's life. Okay, how much it disrupts your life and how much it disrupts your relationships. That is a good measure of, and that is an important measure for most mental illnesses. We measure it based on to what extent this person has changed and to what extent it affects their life. Yeah, so when you mention just negative symptoms, I would say, whether it's part of the illness or part of the medication. One way, like you already mentioned, Julian, is actually the change of medication. And you bring up a very valid point in that for a lot of people, it's a lot of trial and error to find a medication that really fits them and works well for them. So sometimes it's a long journey. So that's why compassionate support from family and friends and church is super important in this case, because it can be a journey, finding the medication that works, that actually has less side effects for the person and that the person is happy to take, right? So it can be a long journey. So I hope that answers the question. The negative symptoms,
it's a case-by-case basis. And you kind of you need to assessment.
You need
clinical assessment that you have to talk to the person. It's like blood test, you can't. There's no. I don't know if they do brain waves, or I don't know if that helps. I don't think they do that.
Yeah, we don't have very much. We don't have very strong studies for it, as far as I know, at the moment. But a lot of it comes from talking lah, just to see who is this person actually, and is what he's experiencing now different from his usual self. A change from his usual self. Yeah.
Sorry, there isn't any test for checking dopamine and serotonin levels yet in the brain, right? There really is there?
Yeah, a lot of it are on study basis lah at the moment. Just like serotonin levels, there are certain very specialized tests that may be that are usually quite expensive and that are done in the context of scientific studies. But we don't routinely do them. No, as far as I know, we don't have any such options. Yeah. So.
Yeah, okay. Not in Malaysia, right? Not in Malaysia.
Yeah. I mean, in a lot of places, we don't. It's not routinely measured either. Even in the UK, Australia, I think it's not routinely measured. No. Yeah. So a lot of it comes down to the therapist and the therapist interview, as well as the family input. The family's observation and therapist observation combined together. To get an idea of who this person is and how much this person has changed, and whether we can call that that change is to the extent of a mental illness or not.
Thank you.
Yeah. Right. Oh, I'm glad to help. Any further questions?
Praise the Lord. I think I've answered all the questions. Mandy.
Yep. I mean, so I hope that's sort of like clear. I hope that we have a bit of an idea.
Yeah, and it's like a good balance between the spiritual as well as the medical side. Okay, so thanks again, Mandy, and we'll see you next week for another interesting talk.
Right.
God bless you all. Have a great week.
Thank you.
Thank you.
Everyone.
See you.
Thank you.
Dr. Amanda.
Thank